Good afternoon. Thank you for joining us for today's webinar titled EBP 101, Toward a Better Understanding of Evidence-Based Treatments, Evidence-Based Practice, and Alternative Approaches. My name is Maxine Henry, the co-director for the National Hispanic and Latino Addiction Technology Transfer Center. I will be your host for today's webinar. Before I introduce you to today's guest presenter, here are some brief instructions about today's events. This webinar will be recorded and archived for future playback. It will also be dubbed and closed captioned in Spanish and eventually also in Portuguese. A copy of today's presentation will also be made available after the webinar. Your lines will be muted throughout the presentation so as to minimize background noise and other interference. When we get to the Q&A portion of our webinar, you will have an opportunity to ask questions by clicking the Q&A box and entering your question there, and I will present your questions to our presenter. We will also be asking you to fill out a brief survey at the end of this webinar. This satisfaction evaluation is important to the work we do and provides us the opportunity to improve our training efforts. Although we did not secure continuing education credits for this event, we are working diligently to make sure that we have them for future events. A certificate of completion can also be sent to you upon request via email post-webinar after you complete the satisfaction evaluation. So let's begin. Let's start by introducing the National Latino Behavioral Health Association, otherwise known as NALBA. It's a nonprofit organization located in New Mexico. The mission and goal of the National Latino Behavioral Health Association is to influence national behavioral health policy, eliminate disparities in funding and access to services, and improve the quality of services and treatment outcomes for Latino populations. NALBA was established to fill a need for a unified national voice for Latino populations in the behavioral health arena and to bring attention to the great disparities that exist in areas of access, utilization, practice-based research, and adequately trained personnel. NALBA's executive director is Fred Sandoval. NALBA's objective is to provide national leadership on mental health and substance use concerns of the Latino community in 5 major areas of focus: policy issues in mental health and substance use, education and workforce issues, mental health and substance use service delivery, Latino-focused behavioral health research, and Latino family-focused interventions. Now allow me to introduce you to our National Hispanic and Latino Addiction Technology Transfer Center and Prevention Technology Transfer Center. Our ATTC and PTTC are part of the TTC network. The ATTC is an international multidisciplinary resource for professionals in the addictions treatment and recovery services field, while the PTTC is an international multidisciplinary resource for professionals in the prevention field. Both were established in 1993 by the Substance Abuse and Mental Health Services Administration, otherwise known as SAMHSA, and the ATTC-PTTC network is comprised of 10 domestic regional centers, 6 international HIV centers, which are funded by PEPFAR, 2 national focus area centers, and a network coordinating office. Together, the network serves the 50 US states, the District of Columbia, Puerto Rico, the US Virgin Islands, and the Pacific Islands of Guam, American Samoa, Palau, the Marshall Islands, Micronesia, and the Marina Islands. The international HIV ATTC-PTTC serve Vietnam, Southeast Asia, South Africa, and Ukraine. Here you will see a map of the US-based ATTCs, MHTTCs, and PTTCs. Both centers have a national focus for Hispanic and Latino communities and the workforce that provides services to these communities. Our ATTC is staffed by Dr. Pierluigi Mancini, who is our project director. I serve as the project co-director, and Ruth Yanez is our executive administrative assistant. Dr. Pierluigi also serves as the project director for our PTTC. Dolca Michelle Zelaya serves as the project coordinator, and Priscilla Giammassi is the executive administrative assistant. We will provide contact information for both centers at the end of this webinar. So now it is my honor to present to you our esteemed presenter for today. Dr. Luis A. Vargas is a retired clinical psychologist and a member of the board of directors of the National Latino Behavioral Health Association. He was on the staff and faculty of the Department of Psychiatry at the University of New Mexico School of Medicine, also known as UNM SOM, for 30 years. He worked part-time at Samaritan Counseling Center and is a which is a Spanish-speaking clinic. St. Joseph's Center for Children and Families, following his retirement from UNM. He was the director of the UNM SOM Clinic Psychology Internship Program for 14 years and served 6 years as the chair of the New Mexico Board of Psychologist Examiners. His clinical and scholarly work has focused on providing culturally responsive services to diverse children, adolescents, and families in Latino communities. He is committed to training mental health professionals to maintain a scientific mindedness in providing culturally responsive services in the context of evidence-based practice and global psychology. He is co-editor of Working with Culture, Psychotherapeutic Interventions with Ethnic Minority Children and Adolescents, and a co-author of Working with Latino Youth, Culture, Development, and Context. It is our pleasure from the ATTC and the PTTC to host this webinar today. Dr. Vargas, please take it from here.
Okay, thank you very much, Maxine. I wanted to start, well, first of all, let me just say buenos días a todos, o buenas tardes, según donde vivan. You know, a good morning or a good afternoon, depending on where you live. I wanted to start first with going over the learning objectives for today's presentation. As you can see, we're going to be looking at EBTs, evidence-based treatments, and evidence-based practice. Now, I'm going to make a distinction between those two. And the reason for that is that you'll understand how EBT, a treatment itself, fits into an overall practice. So we'll be looking at the underlying concepts of EBTs. We're also going to be looking at how EBTs are established and how can we better evaluate them. So we're going to look at the contributions of something called meta-analyses, which is a statistical technique that groups studies in order to analyze them in total and then derive a measure of how big an effect the treatment actually had. So we'll look at those. That's becoming more and more the norm for evaluating EBTs. In the past, it used to be narrative analyses, or now it's statistical analysis. Both are important. I don't want to minimize one or the other. Then we're going to be looking at issues that have to do with the application of evidence-based treatments to culturally diverse populations. We're also going to focus on issues of what contributes most to the outcome in an intervention. So that's more than just the treatment. So one of those components that we're going to be looking at is the counselor-client relationship. And then we'll be looking also at processual issues of implementing an EBT. And we'll be examining very briefly some alternative strategies that are being currently used in establishing EBTs and EBP. And then lastly, I want to at least end on a note of us considering the political power and privilege issues that go with the establishment of any EBT, which is an area that's often ignored. So first, let's begin with the distinction between evidence-based treatment and evidence-based practice, the distinction that I'll be making throughout this presentation. So an evidence-based treatment refers to a treatment that is supported by empirical research studies and has been shown to be efficacious in a sample or samples of population. You'll notice that I use the term efficacious rather than effective, because I'm going to be making a distinction about those two, efficacy and effectiveness. An evidence-based Practice, and I'll use the APA definition, is the integration of the best available research, which is the EBT research, with clinical expertise in the context of patient characteristics, culture, and preferences. The Institute of Medicine had a similar definition as the integration of best research evidence with clinical expertise and patient values. I provided a few extra definitions or characteristics of evidence-based practice. I'll just leave them there for you all to look at. I'm sorry, I went too fast. There you go. But I'm not going to go into any discussion. It's basically the same kind of distinction, but with a little bit more explanation. And you'll have a copy of this later on, so you'll be able to refer to these. Since I'm covering a large amount of information in a very short period of time, I'm going to have to go a little bit fast, so I'll ask you to forgive me if the pace is a little too fast. So, as we were talking about the practice, this is a distinction in front of you that's presented by the Centers for Disease Control, where they look at three types of evidence, really. The research evidence, as I mentioned, or sometimes called empirical evidence, the experiential evidence, which includes the professional insight, understanding, skill that is accumulated over time, sometimes referred to as intuitive or tacit knowledge. And the third aspect is a contextual evidence. That's based on factors that address whether a strategy is useful, is it feasible, is it easy to implement, is it accepted by a particular community? And that brings up, again, a notion of cultural fitness of the application. So this is just a pictorial representation of what a framework for evidence-based practice would look like. It's the confluence of all three aspects that we just talked about. So I want to then pose a question to y'all. Which is true of an evidence-based practice? It can include an EBT. It includes clinical expertise or experience. It takes into consideration client values, culture, and preferences. It takes into consideration context. It takes into consideration client-counselor relationship. So I'll give you just a quick minute to answer that. And we'll be getting to tell in just a few seconds. Okay, so most folks said all of the above, and it is all of the above. And in this distinction, then, you can see how an EBT is actually a part of evidence-based practice, but it is not it in totality. And that's an important distinction that we'll be making. So I'll be moving to the next slide in just a few minutes.
Don't forget to click on it.
Oh, there it goes. Okay, now we're going to be going into a series of definitions. And I'll ask for your patience here because there are a lot of definitions, but we can't proceed without them because the language is important. And anytime we talk about evidence, it's very important to think about this in terms of some basic statistical concepts. And that's what I want to get into. We'll go over them pretty quickly. And if you have questions, you can ask in the end. But these are going to be, as you can see, necessary in order to make a better evaluation of what is the best EBT for my particular use in my particular clinic, in my particular practice. So we're going to, as I mentioned earlier, make a distinction between efficacy and effectiveness. Efficacy is the degree to which an intervention or prevention program achieves its desired effect under ideal, controlled, some people call these lab studies, circumstances. An example of, the best example of that is a randomized clinical trial. The problem with this kind of application is it's very controlled. It has controls over who's in the study and who is not in the study, and how the treatment is delivered, under what conditions and what setting. So the issue here is, does it apply to the real world if it's shown to be efficacious? So effectiveness then is the extent to which an intervention achieves its intended effect in the real world, in a clinical setting or a community-based agency. Is it really applicable in the practice that I have each day? So sometimes effectiveness is linked to external validity. It's not necessarily the case, but oftentimes it's assumed that if a treatment is effective, it can work anywhere with anyone in any place. That's an assumption, I think, that's erroneous, but sometimes that accompanies the idea of effectiveness. I don't think that's the intent, but that's what sometimes happens. So I want to go into three aspects of validity next. The first is internal validity. The internal validity is the extent to which differences between an intervention prevention program and a control group or a comparison group in a clinical study can be confidently attributed to the intervention program and not to something else. So when you apply a treatment, you want to be sure, especially if you're researching it, doing it empirically, that there are no other explanations for it. And that's where the issue of controls around who is eligible to the study, who's not, what kind of characteristics do we want in the sample, so we can be sure that we're just measuring the program and not something else. So internal validity then involves a number of constraints to reduce the confounding factors, that is, other explanations, and to minimize the bias. But it comes at a cost. It comes at the cost of putting too many constraints sometimes, so that it's difficult to replicate that in an actual real life setting. That brings us to our next validity, external validity, the extent to which an intervention or prevention program can demonstrate the same desired effects in a wide range of populations and contexts. A term that's often used instead of external validity is generalization. So the assumption that a treatment program can be used with anyone, anywhere, any place, and it's going to work equally well. That's the idea of an external validity. So I've put then a contrast of ecological validity. Now, my definition is a little bit different than some folks define it. For example, the Centers for Disease Control considers ecological validity as part of external validity. I have to tell you, I don't see it that way. I think they're different concepts. So the way I've come to define ecological validity is the extent to which an intervention or prevention program can demonstrate the desired effects in a particular setting with a particular population. So this is not the typical definition. You do see some definitions that are very much like this, but there's some debate about what it is. I wanted to emphasize that the reason I'm defining it this way is because I believe that we as clinicians or as counselors are interested in how does my treatment apply with the population that I serve in the community I serve. And that's an equally important definition to the comparison of, does this work everywhere in any place? I think as clinicians or as counselors, we're probably much more interested in ecological validity. That is to say, both are important, but as clinicians, our focus is, I believe, in ecological validity. So we're going to define briefly just some designs. The first is random control trials. Most of you may be familiar with those. They're often associated with medication, so you hear that term a lot about what medicines work best. The key terms here are the subjects or the participants are randomly assigned. And there's a control group. And the control group is a group that has, at best, no intervention, and if that's not possible, some comparison. There's very strict rules about inclusion and exclusion. It's considered the strongest research design for establishing cause and effect relationships, but it comes at a big cost. It comes at the cost of saying, well, in the real world, we can't have all these exclusion and inclusion criteria, and we can't have the degree of control necessary in this type of, quote, lab study. So it's a balancing act, right? You want to have a clear indication the treatment works. So you have to put a lot of restraints, but you also want to make sure that it can generalize, that it can be applied in the real world. The next kind of design is called a quasi-experimental design. The key thing here is without random assignment. In other words, in quasi-experimental designs, you don't have that. And you also don't have full experimental control. You know, in an RCT, you could say somebody gets this medicine and the other one gets a sugar pill, a placebo. In mental health, we're often not in a position of saying, we're just not going to treat this person and compare them to the treatment. That's just ethically not feasible. So the comparison groups are often much more realistic in terms of application, but it comes at a cost of being able to establish internal validity. Random control trials control very well for internal validity. But in some ways, the quasi-experimental design has the benefit of having perhaps increased external validity because it's applied in the real world. The next concept I want to touch on is a meta-analysis, which is you're seeing now more and more studies using meta-analyses, which I think can be very useful, but you have to be careful in how you interpret them. And this is a type of systematic review that uses a statistical analysis, one, to combine all the studies, and two, to analyze the data using a single estimate, or what's often called an effect size, to make a statement. In other words, it's looking at how big of an effect do all these treatments that were assessed to be efficacious, how big of an effect did they really have? So we'll be looking at that also a little bit later. And then there's the issue of treatment fidelity and integrity. It's very important if you're going to use, say, motivational interviewing, that you can be sure that people are actually adhering to the protocol that defines how that particular treatment is to be delivered. So you have to have these checks to make sure that people are adhering to it. Because if they're not, if they're practicing something else in conjunction to motivational interviewing, you're not really measuring motivational interviewing. So that brings us to the next part, which is the effect size. Now, I'm going to jump to the bottom first of statistical significance. Most of the studies that have been used to establish evidence in mental health, or behavioral health rather, have used studies primarily based on statistical significance. In other words, that there's a demonstration that the difference was not due to chance alone. So they use a probability value of 0.05 or less, which means in a case of 0.05 that there's a 95% chance that the results you got, that this treatment was better than the other, is 95% likely that it did. What it doesn't tell you is how big an effect did it really have. So that brings us then to effect size. A lot of these studies in the past have not had any demonstration in their studies about effect size. And I believe that as clinicians, we're interested not in statistical significance alone, we're most interested in the effect size. That is, how much of an effect did the treatment really have? And analyses of effect size allows us to see whether, for example, the effect was small, was it medium, was it large? Does it make a big difference? That's more important, I believe, to us clinicians or to people selecting what programs to use in their clinics than statistical significance. And there's another aspect of this too that relates to something called a confidence interval, which I'll go into in the next slide. But I did want to preface my discussion about the next definition with a focus on clinical significance, that clinicians are always in a position of having to decide, okay, this is a statistically significant difference of this study showing that, say, the CBT application for alcohol use works. I've seen that if the study gives an effect size, it's kind of considered a medium effect size. Now, my final decision has to be based on the practical importance of the treatment effect. Is it sufficient? Do I think, and this is a subjective assessment, that given this information about statistical significance and effect size, this treatment is suited for my use in my practice or in my clinic? So that's a subjective assessment, but it's a very important assessment. I wanted to make some distinctions. These are distinctions that I've made to be able to better explain EBTs. The first category is one that I call generic EBTs. What I mean by generic EBTs are evidence-based treatments that are developed on and for the dominant ethnic racial society. And the evidence for these EBTs is based on the studies that have used participants primarily or only from the dominant racial society. And these generic EBTs may or may not use representative samples. The representative sample would say, look, I've got 80% white European Americans, but I've got 15% African American. Well, that small component of 15% is going to wash out because we only look at means typically. Now, there's other analysis that you could use, but those oftentimes aren't included in the studies. They'll just say this treatment worked well with this population, but the population is largely, in the example I gave, white European Americans. So one has to make a distinction there because you want to say, well, would this work with this 15%? Because we don't know how they actually did in the study if you just analyze them alone. So that brings us then to the next distinction, culturally adapted EBTs. I define culturally adapted EBTs as generic evidence-based treatments that have been adapted for the use with a particular group to which they will be applied. So that these EBTs can be culturally adapted, but only to a certain extent because you're limited by the treatment fidelity requirements. And remember that if the treatment was designed for a majority group, the treatment is based on a theory that comes from that majority group. So the idea that you're making adaptations means that you're going to come up against some issues that have to do probably with values, cultural values, cultural norms, and you can't make too many adaptations because that will compromise the treatment program. So the best example of that would be, let's suppose that I was to say to you, I've got this fantastic parent-child interaction therapy that was developed in the Middle East. And it's premised on what is considered in the Middle East to be best parenting practices. And that's what we're going to be teaching you. You'd say, well, yeah, but we're very different from that group. And I would counter with, yes, but this program has been able to be shown as efficacious all over the Middle East. And we're pretty sure it could apply to you. You can see what the dilemma is there. So we can say we can try and culturally adapt it, but we can only culturally adapt it to a certain degree because it starts to violate the basic premises on which that particular treatment was based, that is treatment fidelity. So the next distinction then is culture-specific EBTs. Now, culture-specific EBTs are evidence-based treatments that are developed on and for specific cultural groups. And these EBTs fully reflect the cultural value, beliefs, and norms of the cultural groups to which the EBT is applied. And we'll look at examples of each. the last one is the confidence interval. And the best example here is one that I faced many times as a child clinician. A child is evaluated in schools for a gifted program, and he has or she has an IQ of 130, which is the requirement to get the child placed in gifted. So the kid takes a test, gets 130 IQ, gets placed in the school setting for gifted. 3 years later, you're required to give another evaluation, and he scores or she scores at 125. The parent comes back very upset and says, wait a minute, that's a mistake because 3 years ago he got a score of 130. So there must be something wrong. There may be nothing wrong because an IQ score, any mean has an error, and that error has a range. So in the case of the IQ, one could say if the error is plus or minus 5, and we're using a 95% interval, we could say that there's a 95% chance that the child's true IQ score actually falls between 125 and 135. So anytime we're going to measure, that child could get a score anywhere in that interval. And it's just reflective of the inherent error in any measurement. And that's why it's important sometimes, well, it's not sometimes, it is important for studies to tell us what is the confidence interval of the mean you got. Not that it was just statistically significant, but how wide was that interval? So that brings us to our next question. Statistical significance is superior to clinical significance because it is empirically based. And I'll give you all a few minutes to, or not a few minutes, a few seconds to answer. Okay, and we'll be coming up with the answer is false. And the reason the answer is false is because just because something is statistically significant, remember what we talked about earlier, doesn't necessarily mean that it had a significant effect that as a clinician, one would consider it clinically significant, right? So think about this example. I've measured the effect of a treatment on depression, and I used a Likert scale of 1 to 7. And I can show that there's statistical significance between the group that got the treatment and the group that didn't. Because the group that got the treatment got a score on that Likert scale of 1 to 7 of 5. I'm sorry, 7 being high, so we'll go say 3. And the group that didn't get the treatment got a score of 2.8. You could show that, especially with a big enough sample size, because increasing sample size increases statistical significance, that with a big enough sample size, I showed statistical significance. But you look at those results and you say, man, both of these are basically a 5. So clinically, it doesn't make much difference. Remember that there's an error in every measurement. So the clinical significance issue is important here because you might say, you know, it's not worth replacing the treatment I'm doing with this other treatment because there's hardly any difference at all, even though there is a statistical significance. So the next slide is just a quick representation of, this is from evidence-based medicine, but it applies equally well to behavioral health. That in terms of studies, the random controlled trials are listed as the highest. You'll see a division there because the other ones are group analyses. The highest being the systematic reviews, and the systematic reviews can be, as I mentioned, a narrative, or the meta-analyses. the statistical analyses of these studies. This is another example of a continuum of evidence, again, taken from Centers for Disease Control. You can see that typically what we'll consider well-supported are those designs that are true experimental designs because they have the highest degree of internal validity, followed by quasi-experimental, which some would say we supported but not well-supported. Both of these programs involve independent replication of the program and the evaluation. Promising programs are those that are typically non-experimental designs, and there's program replication in the sense that they've done this in various settings, but there's not evaluation replication. So move that on. So this is just an example of a group, the American Psychological Association, what definition they use to establish their treatment. So well-established treatment in the APA was just 2 good group design studies. The NREP, the SAMHSA list, which is the National Registry for Evidence-Based Practices, had a list of evidence-based programs which you could refer to in making decisions. However, I have to tell you, the criteria was even more lenient than the APA. So the reason it was taken down was that it was considered to be too low a criteria by the incoming director that came into the agency. So I bring this up solely to show you that even though some treatments are described as evidence-based treatment based on some criteria, say of APA or NREP or some other group, right now the criteria for establishing them as evidence-based treatments is quite low. So it's something to consider. I'll skip there. So that brings us to the question of, so what does all this information have to do with EBTs? So the intention of including all these above definitions, which may have been laborious and boring, I apologize for that, but is that they help us evaluate things. So for example, are the studies providing the evidence on the substance abuse treatment or prevention program that you're considering published in peer-reviewed journals? Why is peer-reviewed important? Because peer review means that independent reviewers have looked at the statistics, the design, and the conclusions of the study and assessed them to be well done. So peer review helps quite a bit. Do studies report effect sizes or confidence intervals or some other measure of the overall effect, size of the effect that the treatment has? And if so, what's your assessment? Are they clinically significant? Are they clinically meaningful to you? If the studies report only statistical size, does the difference in means between the treatment in which you're interested in the control or comparison group, is it meaningful? And I just used an example earlier with the question about how statistical significance might not be all that meaningful sometimes. The next question would be, are the samples of the participants used to show the efficacy of the treatment group similar to the ones that you'll be applying as either as an individual practitioner or as an agency? And then the last is, was the treatment prevention program tested in a random control trial, an experiment or quasi-experimental design? Does this fit the kind of situation that you're in, with the population you're in, with the community you're in, with the cultural values that are in the community in which you practice? So that's an important question. And are they practical? Are the findings easy to transfer to the real world? So let's look quickly at some of the limitations of current approaches to EBTs. One is that there's not much mention about specific factors that incorporate into the theories that give rise to these treatments. So the protocols that come out or the manuals that come out will just say simply something like, please conduct this in good clinical practice, be respectful, warm. Well, there's a lot more to that than just those brief descriptions. And we'll look at that in the client relationship aspect. Are the controls credible? Sometimes they're not. I mean, sometimes we're looking at a control group that's a wait list. Well, in the wait list, that person might be going to AA or NA or other groups to seeing their minister, the priest, and they're actually receiving some kind of treatment, but you don't know what it is. So the comparison of usual therapy, or I'm sorry, of the treatment, experimental, or the treatment of interest with the wait list might not be a very good comparison. And then the other thing to consider is that all therapists, whether experimenters like it or not, engage in adaptation. I mean, we just can't help it. We have our personalities and our ways of doing things that are still going to put our own kind of tinge into the treatments that we use. And the next part is that evidence-based treatments are often focusing on average responses. And I mentioned a little bit earlier about that example with 85% white European Americans, that you have a 15% African-American component in your sample, but those are getting washed out in the average response. So you don't really know how that little 15% did in that treatment because it got washed out. And then the last part is that what often has been happening is that these psychology, well, I shouldn't say, just say psychology, mental health, behavioral health in general, is based primarily on efficacy studies. We don't have true effectiveness studies up to this time. There's some programs that are approaching that, multi-systemic therapy, motivational interviewing. Those are starting to perhaps get to the level of effectiveness, but by and large, most of the studies that we're looking at are efficacy studies, studies in a particular population. That's the same point. What the EBTs tend to ignore is who's the person of the therapist, experience, expertise, right? Those issues, the personality, the therapy relationship, and the patient's non-diagnostic characteristics. So research suggests that the effective therapists have a sophisticated set of interpersonal skills, including verbal fluency, warmth, acceptance, empathy, and an ability to identify how a patient is feeling. These are characteristics that are going to have a big effect on outcome regardless of the treatment that is being used. In the case of RCTs, the emphasis sometimes is that you don't look as much of the processual issues, right? Everything's really controlled. So the question is, can we really put this into practice in the real world? I've mentioned that before. So that most RCTs really represent one version of the intervention and one version of the outcome in one setting at one time in one population. And you can see then the problem then with generalization or the real world application. In RCTs, sometimes are too dependent on traditional statistical significance and often don't include the statistics that help us make practical decisions about the value of the results. And there's a tendency, I think, still now to overemphasize efficacy studies. You've got 4 or 5, but it's basically in the same kind of population. So you make overgeneralizing statements about this would work anywhere with anyone. And this is just a quick slide to show you, this is a little bit dated slide, but it gives you an idea that we're still not getting studies that are looking at things that are particularly significant to clinicians. That is statistical power, effect sizes, and interpreted confidence intervals that would help us select a better treatment. That's improving, but it's still not where we'd like it to be. So when is cultural adaptation necessary? If the study shows evidence that's based primarily on a sample of majority ethnic racial populations, the generic studies that I said, it's probably best to culturally adapt. When the study provides evidence, and this is a little bit more of a nuanced distinction, for the EBT that are based on ethnic populations, say an Hispanic population, you assume it's worked with an Hispanic, but the treatment was developed with participants who were 2nd and 3rd generation Puerto Rican, and now we're trying to apply it to a population that's comprised primarily of immigrants from small villages in northern Mexican states. So these are very different populations. And so I would argue that even this kind of notion of saying this should apply equally well should be questioned. And the next part, there's a little typo, I apologize, but is when we value ecological validity over external validity, we probably want to look at either cultural adaptation or culture-specific applications of an evidence-based treatment. Now, the problem with the generic studies, EBT studies that I mentioned, is that they tend to use ethnic groupings rather than cultural values. And representative numbers of ethnic minorities in efficacy studies is not a solution, because for two reasons. One is the representation is often too small so that the majority culture prevails in the means, which washes out the effects of the ethnic minority population. And two, ethnic groupings don't tell us anything about how much that ethnic group adheres to the culture, right? So we might have very Americanized Latinos, and we're using a culturally adapted therapy that in fact a generic therapy would probably work better with them than a culturally adapted one because they're so culturated. So culturally adapted EBTs tend to look then at more of the culture aspect of ethnicity, and that's a big advantage. The treatment, let me go to the next slide. The treatment and prevention programs developed for a specific group may work well for that group, which is high ecological validity, but not for other groups, that is low external validity. And that's an important distinction. Remember that I mentioned that I think oftentimes we who are treating ethnic minority populations are more interested in the high ecological validity issue. Okay, let me, there's relatively few studies that are looking at levels of acculturation, which I think is the next wave that we'd like to see in evidence-based treatments, but that we be able to understand how acculturated is the sample in which these studies were developed. And I gave an example here. There's one study that recently came out, well, not so recently, that's a substance use and treatment outcomes among Spanish-speaking Latinos from 4 acculturation groups. Now, I think those kind of studies are going to be very helpful to us who provide services to diverse cultural groups. And here, what I've done is just present briefly examples of culturally adapted EBTs. There's a culturally adapted web-based cognitive behavioral therapy that was shown to be effective. Culturally adapted motivational therapy. The Promotora delivered Spanish language counseling. That program was developed with adaptation for male Latino day laborers. That also showed positive effects. Now, the problem though with cultural adaptation is that there really isn't a definition for what culturally adapted is. So we don't know the level at which adaptations are being made. And I can give you an example in one that was used in children, in which the person who did the study said was culturally adapted. And what they did was they had pictorial representations of the population on which to base comments, assessments. And they said, we changed the pictures from European Americans to African Americans, and we reduced the reading level from 8th grade to 5th grade. Now, I would argue that that's not a cultural adaptation that's adequate. But then there's some that are extremely adapted. There's a very good adaptation of parent-child interaction therapy, which was developed in a majority culture. And then 2 sets of folks have made cultural adaptations for Latino populations. And they looked at the values and how they assess the parenting techniques that were being used, whether they want to keep all those elements or take some out or adapt some. So those were very involved. And the trouble with a cultural adaptation is it is lengthy. I mean, it takes time to do these kind of adaptations and to measure if they had the desired effect. So here I've given examples of some culture-specific CBTs. Brief strategic family therapy was developed by Jose Shapotsnik. It's been used pretty extensively and has shown very good results. There's Proyecto Juventud Intervention, which was a community-based intervention for families, for kids at risk for substance abuse. There's Familia Adelante from Dr. Richard Cervantes, who's been using that in a variety of different settings already. And those are culture specific. In other words, they were developed with the culture that you wanted to apply to. Now, let me move then to the next part, which is advantages of a meta-analysis. It's superior to narrative systemic reviews because it's done with more control and close look at the statistics in order to make assessments about how big an effect those studies had, which is of more value to clinicians than simply it had an effect or didn't. It overcomes the limitation of small sample studies, which is a big problem sometimes in clinical studies because it's hard to get a sufficient number of folks. I'll leave the other ones for you to look at later, since you'll be getting a PDF. Now, there are biases in these types of studies, and I think it's important to consider. And one of probably the biggest problem in doing meta-analyses is that it would be helpful to know and to have in your sample of studies that are analyzed, those that showed no effect. In other words, the treatment didn't make a difference. The problem is those studies oftentimes don't get published. It's very difficult to get a study published where you show that there's no effect. So that's a huge bias in the meta-analyses. And so you have to go find studies when you're trying to put these into the group of studies you're going to be analyzing. You're trying to get some of those studies, but they're hard to get because they're not published. You have to go directly to the authors, or if you know somebody did a study that didn't show any effects, you might want to get them to give you the statistical analyses they used. So that's a big dilemma. And then sometimes there's not enough studies, so they're pretty small, and that brings up a lot of problems about, well, how much credence do we want to give to those conclusions? And sometimes they include studies that are very broad, and I'll give you just one brief example. I've put 3 examples on the PDF that you'll receive of meta-analyses, but I want to focus on one in particular, this one, which is, this looked at 33, RCTs, not RTCs, but studies that included 34 treatments. And the advantage is now you combined all your subjects, so you've got 3,951. They found a small effect for group therapy. That's not very encouraging. But the problem is that the group therapy that was used is of a wide range. I mean, there's like AA type of groups, and then there's these more kind of support groups, and then there's like these more formal groups. Well, that's a problem because it's not really assessing perhaps the kind of group that we have in mind. So the results get washed out, if you will, if you're looking at a very particular group therapy, but only 2 of the 33 studies use that. And I've provided there some other examples. I just want to highlight this one. It was looking at family interventions. Again, a broad range of different family interventions. So you're not assessing one particular modality of family intervention. But the problem is it had a pretty small amount of studies. But it did show that two of the RCTs, not the based on motivational interviewing, focused on improving parental monitoring and increasing parent caring behaviors. And that's an important finding. The third RTC, parent coping strategies training program aimed at helping parents to respond more effectively to their adolescence in terms of the substance abuse using group discussion and role play had a positive effect. So that begins to help us understand, okay, maybe these kind of programs are better for my use. And I'll skip this one. So what are questions to ask? Are there cultural adaptations for the EBT that I'm interested in? And are the cultural adaptations appropriate? Are there any culture-specific EBTs that more closely match the client population that I plan to use the EBT on? Are there meta-analyses or systemic narrative reviews that can help me select the EBT? And are studies that used meta-analysis of interest too broad? In other words, if the family therapy one might have used all kinds of different theoretically based family therapies that in some ways one wouldn't necessarily think of comparing, but they did it statistically. So let me look at the next part that I want to focus on today, and that is, what are the estimates about what leads to improvement in psychotherapy? This is a classic slide from back in '92 by Dr. Lambert. But what he was suggesting was that 15% of the change, of the improvement in a client is due to technique. And 40% is client extra therapeutic factors, sometimes, unknown factors. 30% is therapeutic relationship. So this was arguing that perhaps, an evidence-based treatment only looks primarily at that 15%. What may contribute even more is the relationship. So I wanted to go into the next slide, which is, there was a group that was put together by the American Psychological Association to look at evidence-based relationships and responsiveness. And these are the three conclusions that I pulled out that are more germane to this presentation. That is, the psychotherapy relationship makes substantial and consistent contributions to patient outcome independent of the specific type of psychological treatment. The therapy relationship accounts for client improvement or lack of improvement as much and probably more than the particular treatment method. And efforts to promulgate best practices in EBTs without including relationship and responsiveness are seriously incomplete and potentially misleading. So the bottom line here is, don't put all your stock in an EBT. Put an equal, if not more, emphasis on looking at what fosters the client-counselor relationship that can lead to greater improvement. And these are, I just put those up there because it gives you some idea of some of the elements of a relationship that have been shown in research to be efficacious. And those things have to do with alliance, goal consensus, empathy, evaluate, feedback is very important, positive regard and affirmation. So that's, again, more for your own reference later on. So that brings us to our next question. What does not contribute to improvement in treatment? The client-counselor relationship, the placebo effect, the client characteristics, the social support the client has, the treatment method, the client feedback, or none of the above. And I'll give you a few seconds to decide, and then we'll move on. And we'll be coming up with the responses in a few minutes. And it's none of the above. And I apologize, that's a double negative. So one could say, you know, hey, that's cheating. So we'll move on to the next. In other words, all those aspects are important in improving the treatment. Oh. So let's see, did I? Oh, yes. Okay, so I want to go very briefly over the processual considerations in implementing evidence-based practice. We really have to look at, I've got this evidence-based treatment I want to put into place. And I'm going to put this into place, and I also want to, of course, not deny the importance of the relational aspects. But what are the strategies I'm using to get that implemented? So for example, there's one strategy that is based on, you know, you've got this treatment that the clinicians who are doing their thing might say, oh no, not another experimental treatment people want me to use. So they're not really buying into it. So the strategy for the buy-in is to get the counselor that has a good reputation among his peers, that his peers go and consult with him and so on, and get that person to buy into it first, and then start the introduction of the program. So that increases the buy-in. That's one example. What's the capacity of the agency? If you're going to maintain treatment integrity, probably the best way of doing it is to maintain supervision. So can you maintain that level of supervision to ensure treatment integrity over time? Is there attention to contextual aspects? You know, where's the clinic situated, and is help available for travel? All these different aspects I think are important in trying to ensure that you can actually carry out the treatment. And is the treatment or prevention program linguistically adapted, including attending to the variation of Spanish? So even something very simple of, you know, just think about, you know, when one person can say, oye, me das, tienes tus espejuelos. And the Mexican might say, ¿Qué es eso? The Cuban says, you know, anteojos. Oh, anteojos, lentes. See, so those kind of things are important. The other is, how will you assess the program? It's important if you're going to implement it to have some type of assessment to get the idea of whether it's having an impact in your local community. So alternatives, I'll go over those really quickly. We're looking then at the balance between ecological validity and external validity. And I've mentioned already some of, I'm sorry, go back. Some of the potential biases, you know, in generic, right? The last one that I want to highlight is the researchers often come from the dominant ethnic racial group or training in US universities. They decide what treatments should be developed on what theories, which are US based, for example, and how the effect of these treatments will be measured. So, you know, we're going to use this measurement for depression, but that depression is characteristic of what depression is in the majority culture. So, for example, there was a study done in the Native American Center in University of Colorado, where they looked at the application of the diagnostic interview schedule, the DIS, to assess various symptoms. And they found that the Native American group didn't find the question asked in the diagnostic schedule to be what they would consider a good evaluation of somebody that's depressed. So they didn't include certain things that Native Americans would have said, this is characteristic of depression in our culture. So we're going to take a very quick look at alternatives to the design of evidence-based treatment. One is something called practice-based evidence, which people began to talk about a few years back. You know, these were probably a common example would be traditional healing practices and so on. And there's been some very good applications, particularly in the Native American community, around integrating traditional healing practices into a treatment practice for, say, substance abuse. So it's bringing practice to science would be the best example of that. The next would be community-based evidence, which is developed by a set of colleagues. And that had to do with, I'll just give you the quick definition of it, a set of practices that communities have used and determined to yield positive results as determined by community consensus. So here's a big distinction. And which may or may not have been measured empirically, but have reached a level of acceptance by the community. That's an important aspect, that the community has bought into it. So that's been another view of saying these are interventions we should use. Now I should mention that SAMHSA has funded several programs in California that are based on this concept, the community-based evidence. The last one I wanted to include is a strategy I think is very important, and it's getting more and more used, but it's still not sufficiently used. And that is community-based participatory research, a collaboration process that equitably involves all partners in the research process and recognizes the unique strengths that each brings. So the idea here would be that even in developing the research questions, the community members are involved. They're informing the researchers. So that's a very important component because it has to do with the acceptability and applicability to the community in which the intervention is going to take place. So that gets just a few more issues around community-based participatory approach. I want to highlight one though. Openly addresses issues of race, ethnicity, racism, and social class, and embodies cultural humility, which is sometimes, I hate to say it, lacking in our research. In other words, sometimes researchers come in and they assume that they're the experts and they're going to tell you what works best for you and how we're going to measure your improvement, which may not be the way the community would see it. So the integration of this is very important. So then that brings us to the next set of questions. How can I ensure that the EBT I select, either for use of myself or implemented in the clinic, will adequately incorporate client relationship aspects to maximize the effect of the EBT? In other words, if you're going to select an EBT, don't underestimate or undervalue the client relationship aspect. It has as much, if not more, of a components in terms of what leads to improvement. And if the EBT is to be implemented in a clinic or agency, how can I ensure that the counselors are giving as much attention to the client relationship aspect as they are to the treatment method? And is the EBT I select based on research studies, oops, there's a little typo, that use any of the alternative enhancement approaches described above? Now, I would say that's important to consider. Are they looking at this? And in selecting an EBT for an agency, does the clinic or agency have the financial, structural, and manpower resources to implement and sustain the EBT? And that's a critical element. It does make sense to do something if you can't sustain it. Now, I want to finish with just a little bit of focus on the cultural, ethical issues of politics, power, and privilege. Years back, Dr. Marcella sent me this quote by an Indian psychologist, Nisra. The current Western thinking of the science of psychology in its prototypical form, despite being local and indigenous, assumes a global relevance and is treated as a universal mode of generalizing knowledge. Its dominant voice subscribes to a decontextualized vision with an extraordinary emphasis on individualism, mechanism, and objectivity. This peculiarly Western mode of thinking is fabricated, projected, and institutionalized through representation technologies and scientific rituals and transported on a large scale to the non-Western societies under political economic domination. Now that is a really strong statement, but you can see what the issues are. That we in the US who have the capacity to do these very well-funded, extensive studies can have a tremendous impact in promoting our culture when we don't even realize we're doing so. That they're based on a particular way of looking at the world, the American epistemological perspective. And so that's something to bear in mind. I mean, it brings up issues of ethics. And also, are we inadvertently in promoting some of these generic or culturally adaptive programs, actually engaging in the accelerating the acculturation process of a particular group into the American mainstream? I just want to mention that, you know, every treatment is based on a theory, and those theories are culturally based epistemologies, meaning that it's the way our culture looks at the problem and the solutions to that problem. And that's a constraint that sometimes is defined by the culture. And sometimes we don't take that into consideration. Guillermo Bernal has said, you know, this is an exportation of, the exportation of EBTs is another form of cultural imperialism. In other words, that we're sending something to kind of dominate a culture and acculturate them to our way of thinking and our way of looking at problems and our way of looking at solutions to those problems. So I would say these are important considerations. I'm not saying we shouldn't do any of these things in terms of putting EBTs into effect, but it needs to be an element in the decision we make and in the way we implement it. So let me end there and say thank you very much for the opportunity to present this. I apologize if this was a lot of information in a very short amount of time. I'm hopeful that the PDF that you'll receive will help you clarify some of the issues.
Dr. Vargas, it was a lot of information, but please do not apologize. It is information that we all need and can use, you know, as we continue to improve our service delivery for the communities that we serve. So thank you. So we're at our Q&A portion. I do have to tell you, I don't know where you were when I was getting my MSW, but I would have loved to take a research class that you were the professor for, and I'm sure that after this webinar, everybody's going to feel the same way. So throughout your presentation, you got a bunch of kudos and thanks for, you know, the clear and concise information that you gave. So we appreciate it. I want to start there. We're going to get to as many questions as we can live. Anything we can't get to, please know that we will follow up on our websites with Dr. Vargas and get the rest of the questions answered on our website. So let's start with Carlos Santana. Said that he understood that you said that treatment that works for a Puerto Rican cannot work for a Mexican, etc. Can you explain that a little bit more?
Oh, sure. Yeah, it's not that it cannot. The key would be it may not. We don't know for sure. Let me give you an example. A few years back, we tried to apply a program, family therapy program that was developed primarily for Caribbean Hispanics. And we applied it to an immigrant Mexican-American population, a Mexican population in Arizona. That was primarily rural northern New Mexicans. It worked, but it didn't work as well. And the reason was that, you know, the way that people intervene in the intervention, which is part of the intervention protocol, which means you had to do it because of treatment integrity, was perhaps a little bit too intrusive for that Mexican-American population, for which it would have been particularly okay with the Caribbean population. And it had to do with the Northern Mexicans. The fathers tended to be, you know, I mean, you could even talk about sexual issues, you know. And I'll give you just a real quick example. Years back, I was doing some family therapy, and it was a Cuban woman who had fled with her family an abusive husband, and she marries northern New Mexican man. And they're going out to the wife liked to go dancing salsa. He doesn't dance salsa because he just doesn't. His boots don't allow him, I guess. Anyway, so she decides, to go, and then her daughter, who was from the husband's, from the husband in Cuba, reaches the age of puberty, and she gets, I'm sorry, not puberty, but she reaches the age of 15. So she now can go dancing with her mother. So they're in the front, in the bedroom, in front of a mirror, and they're primping. And the mother says, "Oye, qué buenota te ves." And then the husband says, who's the northern Mexican, "Can I speak to you in the kitchen where the kids can't hear us?" And he says, "What are you doing? You're raising her, sexual, she's, you've got sexual issues, and this isn't okay." And so he's very indignant that they're talking about this. She's really normalizing the sexual development of her daughter in their cultural tradition, but it's not in his cultural tradition. So in her naivete, the mother says to the husband, to the now husband, second husband, "Oye, qué guapo te ves cuando te enojas," and she pinches him in the butt. And he's like, "Oh my God, you don't understand what this is doing." So that's kind of what I'm getting at. I hope that gives you a sense of what the issues are in the implementation of some of these with even the same ethnic group, but really very different cultural groups.
Makes sense. So I think what you're trying to say also is that there are nuances, that we can't just assume that if something
Right.
is adapted for a Latino community, that it's going to work for all of us.
Yeah, that's right. I mean, that you have to be able to consider those nuances because they can make a huge amount of difference.
Right. Okay, great. Sean Stevens asked, don't meta-syntheses provide valuable insight for cultural adaptation that might not be revealed in meta-analyses?
Can you say what kind of analyses was the first? I didn't quite.
Sure. The first one was meta-syntheses.
I am not that familiar with meta-synthesis, so perhaps, too bad he can't enlighten us a little bit on that. If by meta-synthesis, you're talking about, yeah, I mean, there are some studies that are looking at specifically cultural adaptations. So I think that the meta-analyses that are of interest to us sometimes are the studies that are either culturally adapted to the group that we're intending to use it, or culturally specific to the group we're intending to use them. But those studies aren't in the literature right now because it's just those kind of adaptations or specific therapies are just getting developed. So it takes time between the time that they get developed, implemented, evaluated, published in the literature, and then subsequently analyzed.
Thank you. Thank you for that. Okay, so we also have a question in the chat box. I'm going to try to get here. Dr. Daniel Santisteban asked, isn't it possible that some EBTs have guidelines and strategies for improving therapy alliance, for example, emphasizing collaboration with the client, so that the differentiation between EBP technique versus the alliance may not be so straightforward?
No, that's very true, Dr. Santisteban. That there are some programs, I mean, the one y'all have, the strategic family therapy, pays a lot of attention to that aspect. I think, some programs, particularly family-oriented programs, if you look at some of the protocols, they put a much more emphasis on that aspect than, say, some of the CBT, cognitive behavioral treatment manuals. So there is a big variation. And there are some EBTs that are putting a substantial amount of attention. And I think that's increasing as time goes by to all those relational aspects that are important. And what's nice about some of the family therapies, y'all's are included in this, is that they bring up the client counselor relationship in the context of that particular treatment. So it's integrated into the intervention.
Okay, thank you. Kathy Duttridge, and I apologize if I mispronounced your last name, Kathy, asked, can you please further explain the difference in adapting culturally versus ethnically?
Yes, you know, ethnic is just a distinction, an external category imposed on a group, right? You're Cuban American, you're Mexican American, you're American Indian. It doesn't really tell you anything about the beliefs of that group. So that, you know, when somebody says, you know, we've included 25% Latinos, but then you look at the composition of those, and they're Dominicans, they're Cubans, they're Puerto Ricans, they're Peruvian, they're Argentinian, and they're Mexican. Those, I would say, yeah, you're grouping them ethnically, but culturally, they may have very different beliefs that unfortunately are not tapped into in making that adaptation.
Okay. This is all amazing information. So let me see. We have a mix of a question comment. So Sherry, and I don't want to chop up your last name, so I apologize, but Sherry said, excellent presentation and information. I can't help but feel frustrated that for funding, we are required to implement programs that are culturally biased and maybe even ineffective for some populations. But if we don't use EBPs, we can't receive funding. It is not realistic to be able to use different curriculum in multicultural groups. Do you have any suggestions for best practices to meet the needs of those we serve under our funding constraints?
Wow, that's a very crucial question and equally difficult question, but it's so true. And, you know, that's been one of the unfortunate decisions made, is when folks say you have to show that the treatment you're using is an EBT treatment, because it may not be applicable to your community at all. I think, you know, the ways in which we can do this is through our own respective organizations. You know, for me, the American Psychological Association, you know, getting active with them and trying to promote different views of that are important. You know, a social worker being active in their social work organization, or a counselor in their social organization. I think we really have to start voicing our opinions. And I can tell you, just from my own personal experience, you know, I had the opportunity to be on a task force for the American Psychological Association on evidence-based practice with children. And I very much appreciated that opportunity, because it gave us an opportunity to focus on some of the issues that we've talked about in this presentation, but to look at this in a much more systemic, broader way that brought the primacy of the community and the populations that we're serving to the forefront. But I think we, you know, unfortunately, it's something that, you know, to have a voice, you have to get active somewhere to express that voice in a way that can be heard. So that would be my suggestion, perhaps a very naive one, but I do think that we from the ground up have to begin to express our concerns. And, you know, it's great to see applications that are using, for example, the participatory approaches, because that's getting the population of interest to have a voice in the way these treatments are developed and analyzed. But I think we all have to be active in any way we can to voice those opinions in ways that we hope can be better heard.
Thank you. And I hope, and I know that questions about funding are always really difficult to answer, right? Because unfortunately, we don't hold the purse strings, but I think if you're trying to tackle such an important question, and we have some more questions around funding that I think we'll have to get to in our follow-up.
Okay.
because I think that they might be just as equally as difficult to answer. So I think we have time for one more live question, and I want to remind everybody that even if you want to still submit questions, we will get to them in a follow-up event on our websites. What are your thoughts on controlling for race, ethnicity, and statistical analyses that examine efficacy and RCTs on programs or treatments?
Well, one is, I would say it's helpful to begin to look at ethnic groups in these, what I would call generic EBTs. But I think if you're going to do that, I would say you have to have an analysis that allows you to de-aggregate the data, to pull out those 15% minority group persons, say African American, and analyze that data separately. But I also think that ethnic groupings are not the best way to look at interventions, because what we're essentially interested in is the cultural values, beliefs, and norms of the groups, not whether they consider themselves Mexican American or not. So as I mentioned earlier, acculturation plays a big role. So for some ethnic minority folks, if they're very acculturated, the generic program might work just as well. And it doesn't need an adaptation. But the first generation and second generation folks may need an adaptation. So those are the things to consider.
Thank you. Well, Dr. Vargas, on behalf of NALBA, the National Hispanic and Latino ATTC and PTTC, and our community, we want to thank you for this amazing presentation today. Again, in a couple of days, everybody will have access to a recording of this presentation. It'll eventually also be available in Spanish and in Portuguese. And everybody at that same time will also have access to a PDF copy of the accompanying presentation. If you have any specific questions about EBPs, EBTs, and cultural adaptation, Dr. Vargas has allowed us to share his contact information, which is on this slide. Here you will find the contact information for the National Hispanic and Latino ATTC, as well as NALBA. And on this slide is the contact information for the National Hispanic and Latino PTTC. Please reach out to both the ATTC and the PTTC for, to request free training and technical assistance, to ask questions, also to view and have access to all of our previous webinars that again are in all 3 languages.
And I'd just like to add, if I can, thank you to the folks that ask questions. I certainly don't declare myself any expert in this area. So I think it's something that we as a group have to begin to give much more thought to be able to eventually impact policy. So the more of us who do this, the much more appreciated. The more you can contribute to it, I very much appreciate that as well.
Great, well said, I agree with you, but you are an expert. Here, I just want to say it's our honor to invite you to our conference that will be coming up in September in Los Angeles, California. It's the 2020 Latino Behavioral Health Conference, Shaping the Vision of Latino Behavioral Health Equity. If you visit our website, our webpage, at www.nlbhconference2020.com, there is still time to submit a proposal for a presentation and to register. Early bird registration is still open. We hope to see you all there at this important event. So we do want to ask you all to please take a couple of moments to fill out our satisfaction evaluation. This is really important to the work that we do. We are funded federally, and these satisfaction evaluations allow us to really improve our trainings and deliver to you all the best quality work that we can. And so we want to hear from you. We do read these satisfaction evaluations. We actually share them with our presenters. So Dr. Vargas will get to hear what you all thought about his presentation. Because this is a joint effort, we are asking you to, if your last name begins with the letter A through M, please choose the ATTC from the drop-down menu at the top of your satisfaction evaluation. If your last name begins with N through Z, we are asking you to please choose the PTTC. You will be redirected automatically at the end of this webinar to the satisfaction evaluation, or you can use your smartphone with this QR code or click on this link now to complete that satisfaction evaluation. Thank you all. Take care of yourselves, take care of each other, stay healthy. Thank you for joining. Thank you, Dr. Vargas.
Thank you. And thanks to the audience.